Now, these are my objectives. It's to identify and differentiate various causes of chest pain, assess the various changes in electrocardiogram and application of biomarkers in assessment of suspected acute coronary syndrome, and apply this knowledge in decision making, integrate various clinical and investigative data on chest pain, and to come to further management decisions, and discuss the hospital management of non-ST elevation ACS in brief. Now, why am I doing this talk? Because it is so important that making a proper diagnosis of chest pain would be life-saving. And there are many mistakes committed even now, even with lots of knowledge and technology, still mistakes are being committed. Now, if you look at the dimension of the problem of ACS or acute coronary syndrome, around 25 million ACS occur annually globally, and 60% of them are non-ST elevation syndromes. And this causes about 6 million SCDs, sudden cardiac deaths, every year. And at least 60% of acute deaths due to ACS is preventable by timely intervention. And timely intervention means making a correct diagnosis, the most important thing. Many a time, this is what is missed. About 20 million chest pain ED attendants happen in US and Europe annually. And approximately 5% of these patients with MI are discharged from ED with improper diagnosis. That means they are discharged without making a diagnosis of ACS, and hence may or may not land up in problems. And missed AMI accounts for 20% of US medical litigation. And the most prevalent reason for litigation is erroneous diagnosis leading to patient injury. So this is why it is so important to make a timely diagnosis of acute chest pain. And many a time what we find that even doctors, highly trained, even trained doctors, make mistakes in diagnosis and management of acute coronary syndrome. Heart attacks can be rapidly fatal, which everyone knows. And half of the deaths due to MI occur before the patient reaches the hospital. As Bernard Lown said, those who reach the relative safety of CCU are the survivors of a massive shipwreck, which has already taken a heavy toll. So that's why it is so important to make a proper diagnosis as soon as the patient presents to you. Now I will go through some terminology. ACS, or acute coronary syndrome, indicates a constellation of symptoms, signs, and outcomes resulting from acute myocardial injury due to a total or subtotal coronary occlusion. Now, the term STEMI, or ST elevation MI, is used when ACS presents with typical persistent ST elevation in at least 2 contiguous links. Whereas non-STEMI or non-ST elevation is ACS without persistent ST elevation. So these two groups, that is with persistent ST elevation and without persistent ST elevation. Now, previously the STEMIs were called transmural MI or QMI, whereas NSTEMIs were called as subendocardial MI or non-QMI. But the current this terminology is the one which leads to a proper acute management, and hence is accepted all over the world. Now, under NSTEACS, if there is no elevation of cardiac biomarkers on serial examination, it's called unstable angina. Whereas if there is elevation of cardio biomarkers, particularly high sensitive troponin, then it's called NSTEMI. It's a myocardial infarction. So myocardial infarction is acute ischemic injury to heart with troponin elevation, simply stated. Now, the fundamental pathophysiology of all acute coronary syndromes are same. STEMI and NSTEMI are nearly similar and differ only in degree of disability. Now, if you, it's a familiar diagram which you look at echo. Is there echo? A plaque develops in the walls of the artery which builds up and ultimately it ruptures. And this rupture is so unexpected and unpredictable. And the rupture may cause a clot which may occlude the artery subtotally or totally, resulting in either a STEMI or an NSTEMI or unstable angina. Unstable angina may be also due to spasm of coronary arteries. So whether the patient would develop a STEMI or NSTEMI depends upon the severity of occlusion, whether it is subtotal or total, how much of collateralization is there in the jeopardized area, and also the site and the duration of occlusion. Now, when you confront a patient with ischemic chest pain, the first working diagnosis is ACS when the patient comes to the casualty. And then the ECG is taken. If the ECG shows ST elevation, persistent ST elevation, it's called STEMI. And then the patient goes for an immediate reperfusion strategy. If there is no ST elevation, it is called non-ST elevation ACS. Now, the further classification of unstable angina or NSTEMI comes only after serial biomarkers are available. So the final diagnosis is only after the serial biomarkers. Now, if you look at the comparison between STEMI, NSTEMI, and unstable angina. Now, in STEMI, almost always there is total occlusion of a major coronary artery. There will be persistent ST elevation, and troponin, that is high sensitive troponin, are very high, usually above 1000 nanogram per liter, and the peak levels. And there is high acute mortality if not properly treated. NSTEMI is usually due to a subtotal occlusion, but can be due to a total occlusion also. And there is no ST elevation, and the ECG may show variable changes or no changes at all. ECG may be completely normal. And the troponin levels are usually between 50 and 1000 nanogram per liter. The acute mortality is less than STEMI, but the 6-month mortality is almost the same. In unstable angina, there is usually some form of occlusion. It may be subtotal, it may be a spasm. There is no ST elevation. Usually the ECG is normal and there is no drop T elevation. That's the most important. If there is no drop elevation, it is unstable angina. And that is a low risk situation. So any chest pain, acute chest pain is a diagnostic challenge. So there are 3 components in diagnosis, and these 3 should be applied in patients with acute chest pain. One, the nature of chest pain or discomfort, the features. Second is the electrocardiogram. Third is cardiac troponin, that is high sensitive cardiac troponin. Now, what are the major causes? I will dwell a little bit on chest pain because history is the most ignored aspect of evaluation of chest pain and coming to a diagnosis in the ED. Most doctors do not take time to take a proper history and come to a working diagnosis before ECG is taken. Because many a time the ECGs are normal or only have non-specific findings. So it is the nature of chest pain and the pre-existing conditions and risk factors that constitute the working diagnosis which leads to a proper final diagnosis. Now, causes of chest pain could be either serious or life-threatening or non-life-threatening. Just like any other symptoms on the body, a particular symptom can be very trivial and of no consequence, or it may be even life-threatening. Chest pain is no different. It may be an acute coronary syndrome or acute PE, which are the commonest serious conditions, but it could be dissection, pneumothorax, pericarditis, or other rare conditions. Whereas non-life-threatening, the most common would be chest wall pain or GERD, cervical spondylosis. These are the three which constitutes more than 95% of non-life-threatening, non-cardiac chest pains. But you must remember all these conditions whenever you approach a patient with chest pain. You should have a checklist. Because many a time missing diagnosis is not because of lack of proper care in taking history or physical examination, but not thinking about the diagnosis, the possibilities. Now, classical ischemic chest pain or angina is central. That is very important. It's usually or most often it is central. Sometimes it will spread to the left side, very rarely right side. It is diffuse, constricting or pressure or expansion, or even, not even as mentioned as a pain. It may be just mentioned as a choking or a shortness of breath. Usually lasts for only 5 minutes, 20 minutes, or even less than that. Varying intensity. Radiation need not be there. It's not a very important finding, but if it is there, it is useful. Recurrence is a very important thing. Usually these warning pains occur in clusters of several episodes of 5 to 20 minutes, and then it may go into a major heart attack. Now there is something called Levine sign, which means that the patient, when he explains or describes the pain, keeps the hand on the sternum. If a patient keeps a hand on a sternum and they say, then they have a central chest pain, and most likely it is ischemic. The other thing which is also useful, and I use it very often, is anger anemi. Many a time the patient feels a sense of impending doom, and this is very specific for ischemic cardiac pain. Most other pains do not have this, the sense of impending doom. You can ask the patient whether they feel like that. And the temporal behavior, that is the coming and going and multiple episodes, is the most important feature of angina. Now, these are some common conditions, serious conditions, which may be differentiated from ACS. In dissection, the chest pain is usually severe at the onset, and generally it migrates from anterior chest to the posterior chest and downwards. And there may be changes in the pulse, hypertension, etc. Whereas in acute pulmonary embolism, the major finding is dyspnea and tachypnea, tachycardia. But chest pain also may be there. It may be central or lateralized pleuritic. In pericarditis, the central discomfort is worse on lying or swallowing. Chest wall pains are sharp and localized, and they increase with respiratory movements or chest movements. And there may be tenderness. There may or may not be tenderness. And esophageal reflux causes central chest burning or discomfort. There may be odynophagia, response to drinking water or milk, acid reflux, and persistent for several hours, more on lying down. So these are some useful features by which you can differentiate, but many a time you need further investigations to make sure. So in many cases of chest pain, the pain is atypical and physical examination is unrevealing. And the patient may have two problems, a chest wall pain with tenderness, but also an ACS. So just the presence of tenderness doesn't rule out, if there is a central discomfort, you must consider ACS. So there can be several scenarios, a typical chest pain with normal ECG or typical ECG changes, or a typical non-cardiac chest pain with normal ECG, or an atypical CP, which is much more common. ECG, there are several features which indicate acute ischemia. The high-risk ECG changes of acute ischemia are ST depression with upright T wave. It's very important. ST depression with inverted T wave generally doesn't, it's not that important. It is generally doesn't indicate ischemia. It may be due to LVH or other conditions like bundle branch blocks or WPW syndrome or digoxin, etc. Whereas if there is upright T wave with a horizontal or downsloping ST depression, it is very classical, particularly if it is dynamic. Or more than 2 millimeter symmetric T wave inversion. Symmetric T wave inversion. That means the downslope and upslope look the same. And then there are low risk STT changes like less than 0.5 millimeter ST depression or T inversion less than 2 millimeters. Pathological Q waves indicate old MI and increase the likelihood of ACS. Now this is the ECG which shows horizontal ST depression with upright T waves. In V5, V6, you can see the horizontal ST depression with upright T waves. This is very characteristic of acute ischemia. And whenever this is present, a red flag should come to your mind. Now this is another example. This is a downsloping ST depression with upright T wave. Downsloping ST depression with upright T wave. Now ischemic T wave inversions are generally symmetric. They are called arrowhead T waves. Whereas non-ischemic ones are asymmetric. So symmetric T inversion, whether it is more than 2 or less than 2, should indicate ischemia, particularly if it is dynamic. It was not present in the previous recent ECG. Now, Wellen syndrome is a specific situation where the patient presents with typical angina or chest pain, and there is a dynamic T inversion in V2, V3, sharp symmetric T wave inversions. In V2, V3 prominently. It may be biphasic, like upright and then downward, or it may be deep symmetric T wave inversion alone. They are called type A, which is this, and type B, which is symmetric T wave inversion alone. So it is biphasic in type A and uniphasic inversion. Now, Wellen syndrome was described in 1998, I think, by D. Swan. And it was correlated very well. Actually, there is around 100% correlation with a proximal LAD occlusion. So these patients should be. See, sometimes you find that V1, V2, V3 has T inversions, and you try to ignore it because it may be a normal phenomenon. But when a patient presents with chest pain and you find these T wave inversions, then it should be considered ischemia until proved otherwise. Don't dismiss it as normal variation or persistence of juvenile pattern, etc. Now, the another sign is called D Winter sign. These are also subtle, not really subtle, but less well recognized. Now, here what you see is that there is ST depression with horizontal, with upsloping ST, upsloping ST with a tall, sharp T wave in V2, V3, V4, etc. Now, this is one of the very early signs of acute occlusion of coronary artery, which may lead to ischemia. So, it's very important to recognize this pattern in a patient with chest pain and should not be ignored. Now, this is considered as STEMI equivalent because most of these patients develop STEMI when you take an ECG later and should be taken up for immediate reperfusion. ECG may be normal in interpain intervals. This is a very important thing, and many a time it is normal. If typically abnormal, then it indicates high risk for acute events. If previous ECG is available, you may compare this with the previous ECG. The most important thing to remember is a completely normal ECG does not rule out acute coronary syndrome. It should be correlated with symptomatology. Now we come to cardiac troponins, which is one of the most important recent innovations in the diagnosis of acute chest pain and acute coronary syndrome. And it's been so vital that this has changed the whole landscape of diagnosis of non-ST elevation ACS. Cardiac troponins are regulatory proteins on the myocardial filaments troponin I and troponin T are the ones which we measure, because troponin C is not specific for heart. But these two, I and T, are very specific for heart. It gets released when there is a myocyte injury and the myocyte membrane integrity is disrupted. They are very sensitive and highly cardiospecific, and it indicates both and quantifies myocardial necrosis. It's a prognostic marker for short and long term. And with the advent of high sensitive troponins, other markers like CKMB, copeptins, and many other biomarkers have found no role now in the diagnosis of acute coronary syndrome. Now, high sensitive troponin is a recent introduction during this century actually, and it has changed the whole thing. Actually, it is much better than the conventional troponin because it has very high analytical sensitivity, so that lots of myocardial infarction, more myocardial infarctions are diagnosed now with high sensitive troponin. And it will reduce the troponin blind intervals, leading to earlier detection of acute MI, so that you can diagnose or rule out myocardial infarction within 3 to 6 hours. So the ER stay and admissions are quite reduced. And it has a very high precision. The previous troponins had more than 20% coefficient of variation, which are called CV, at the cutoff levels. So the margin of error was much more, whereas now it is less than 10%. With good analytical setup, it can be even less than 5%. So it's much more reliable, much more sensitive, and much more early in detection. Now, troponin levels are not static. It rises to above cutoff levels, that is the 99th percentile levels, within 2 to 3 hours, usually 3 hours, and then reaches a peak at 24 hours, and then gradually goes down and takes about 9 to 10 days to come back to normal. So, if you check the troponin at this point or this point, it may look like normal, and hence you may dismiss that case as a non-ischemic problem. So it's very important to do serial troponin levels because of this dynamic kinetics of troponin levels. Now, with the advent of cardiac troponins, the diagnosis of unstable angina has become very rare now, because most of the acute coronary syndromes, there will be some diagnostic elevation of troponin, cardiac high sensitive troponin, and hence they are diagnosed as myocardial infarction or NSTEMI. So this is an article published in the Circulation in 2013 by none other than Eugene Braunwald. Unstable angina is a time for a repeat. At the moment, it is estimated that only less than 2% of cases of non-ST elevation ACS constitute unstable angina. And these cases are probably due to intermittent spasm, or some are not truly angina, but typical chest pain, but not truly angina. So in a nutshell, most of the significant ischemic non-ST elevation ACS would show elevation of troponin by serial examinations and can be used to rule out an ischemic syndrome. And this is a big step in diagnosis of acute chest pain. Now I will just share with you a small clinical vignette which highlights the importance of overall evaluation of chest pain and the importance of correlating various findings in ECG and troponin before coming to a diagnosis and dismissing a case of chest pain as non-cardiac. Now, this is a 48-year-old male who had typical central chest pain at 9 p.m. on a given day and reaches the ER at 9:30 p.m. And an ECG was taken The ECG was taken, which was normal, and the patient was discharged home. The troponin was 7 nanogram per liter, drawn at 10 p.m. The patient pain was at 9 p.m. The troponin was drawn at 10 p.m. and patient was sent home. Patient reports back to ER in the morning as he had more severe pain at about 6:30 a.m. And ECG was taken at 7:50 a.m., which was reported by the ECG computer as non-specific abnormality. But he mentioned that it is an abnormal ECG. But again, this was not very seriously taken. Patient was observed in the ER and trop was sent. And a repeat ECG after half an hour showed this, and this was looking a little abnormal, and the patient was referred to cardiologist. And the troponin at 8:15 came as 1234, which is very high. And then the patient was taken up for angiogram immediately. It showed a complete occlusion of the left anterior descending artery. This is where the left anterior descending artery should be coming like this. So it is completely blocked there. And he was taken up for angioplasty. A wire was passed and dilated, and a stent was put. And this is the LAD after the angioplasty. It's flowing well. So he was saved, but he ended up with an ECG like this. So he developed a Q infarction, an infarction actually. So what really went wrong? The problem was the typical nature of the chest pain was ignored. That was the most important thing. A central chest pain in a patient who is a 48-year-old smoker should have been considered, and patient should not have been sent home. The ECG findings, the classical D ventrous sign, was completely missed. This is the D ventrous sign, D ventrous sign, upsloping ST with sharp T. This is not due to hyperkalemia. In a patient with chest pain, this is infarction coming. So that was missed. And the normal trop T was done at 30 minutes of pain. So it could have been normal because it was done too early. Serial trop was not done, and the patient was sent home. But unfortunately, he didn't die. So this is a very important example which shows the importance of all the things like chest pain, the ECG, and serial troponin. Now, HS, troponin, T, and I, the limit of detection, that is the lowest limit of detection, is 5 nanogram per liter for trop T, which is higher in trop I. Actually, this one is trop I, this is trop T. I forgot to write this. Trop T here, trop I here. And the upper reference limit is 14, usually 14 to 20 in various labs. Each lab has its own reference levels. It's higher in top I. And ACS cutoff is 50 and 400. So this is how you should look at these three values. The LOD, the URL, and the ACS cutoff limits should be always remembered. Now, trop T can be elevated in non-ischemic conditions also. So this slide shows you the usual levels. Now 5 to 14, 5 is LOD, 5 to 14 is the normal healthy individuals up to that. But it can be also due to unstable angina, where the chest pain is typical, but the trop T is normal. 14 to 50 can occur in various conditions, of which the commonest are LVH, CKD. Now in CKD, the levels are usually high because of the inability for the kidneys to excrete the troponin properly. So what you find is a stable level. If it is 28 today, it will be 28 tomorrow, 30 tomorrow, day after tomorrow. It stays the same in all these conditions like CKD or LVH. It can also be elevated in CHF and pulmonary embolism and various other conditions like shock, sepsis, critical illness, any critical illness, stroke, SVT, etc., etc. It can also be this range in early NSTEACS. So such cases, the important thing is the rise. If you take it after 3 hours, it will be higher. And these levels indicate NSTEMI, STEMI. COVID-19 also you can have. Myocarditis, various types of myocarditis you can have. Cardiomyopathies. So there's a lot of conditions where troponin can be elevated. So overall the overall evaluation is most important. Now, there are several high-sensitive troponin-based early rule-out algorithms. In most Western countries, they don't have enough beds in the ED or hospital. They want to rule out ACS in a hurry, and patients can go home. So there are high-sensitive troponin-based rule-out algorithms are developed. There are two types. One is called one-hour algorithm, where you take the patient should have had an chest pain more than 3 hours. That's very important. The index chest pain should be more than 3 hours. The trop T is taken at the time of presentation and then 1 hour. There are 3 zones actually. Less than 5, that is the most one is saying. Less than 5 at 0, and the patient is more than 3 hours of pain, it is ruled. Then you have less than 14 and less than 3 nanogram increase. Then also it is ruled out at 1 hour. Then more than 50 nanogram per liter or more than 5 nanogram increase. If it is more than 5, then it is rolled in. So if the patient comes after 3 hours of chest pain, if it is less than 5 nanogram, a single value is enough to roll out. If it is 5 to 14 nanogram, then you have to do it again 1 hour. And if the increase is less than 3 nanogram, then it is ruled out. If it is more than or equal to 3 nanogram, you have to repeat it after 6 to 12 hours. If it is more than 50 nanogram, or if it is more than 14 plus more than 5 nanogram increase, then ACS is ruled in with a reasonably good positive predictive value. You have to look at other clinical parameters also. Intermediate values are considered to be observational zone and should be repeated after 6 to 8 hours. In some cases, the troponin rises only after 12 to 24 hours. So if the chest pain is typical and or an ECG finding is there, you have to wait. You have to observe, admit the patient and observe. There are other algorithms like 3-hour algorithms also. Fundamentally, it's the same. So basically, when you have a chest pain patient with ECG changes or not, you must, if the working diagnosis is ACS, you must start anti-ischemic, antithrombotic management immediately. Loading dose of aspirin, clopidogrel, and other drugs. Then wait for the troponin levels and come to a conclusion. So chest pain more than 3 hours, trop T less than 5 ruled out, 5 to 14 with delta less than 3 ruled out, more than 50 or more than 14 with 1 hour more than 5 delta, then ruled in. Other cases, observe, admit, and repeat after 3 to 6 hours. All cases less than 3 hours of pain or uncertain index pain, that's very important. Trop T should be done as 0, 3, and even more than that. So this is the algorithm. This should be followed in most cases of acute chest pains. To summarize, a clinic careful history with focus on nature of discomfort, index pain, and diligent physical examination, ECG, serial troponins, and correlation of ECG with troponin are very important. Never discharge the patient with central chest pain discomfort without serial ECG or troponin. Now, in some cases, CCT, that is coronary computed tomography angiography, is useful to rule out ACS. It can actually rule out three conditions. It can rule out or rule in CAD. It can rule out pulmonary embolism or dissection. It's called a triple rule out. Sometimes used in several centers. But in an otherwise usual case, the ECG and troponin are enough. But if there is a doubt of a dissection or embolism, you must do a CT. Now, risk assessment, there are several scores like PME score or Graves risk score, which are available on the internet. Now, coming to the management, the most important component in the management is antithrombotic treatment. Now, if the patient is in pain, nitrates can be given, or if there is persistent ischemia or hypertension, IV nitroglycerin can be given. Beta blockers should be given in all non-contraindicated cases during the first 24 hours. The renin-angiotensin-aldosterone blockade should be given in patients with LV dysfunction or diabetes. Now, this is most important. You have to give dual antiplatelets, aspirin loading, clopidogrel, prasugrel, or ticagrelor loading. Now, these clopidogrel is still considered as the standard, but in the European guidelines, it has been given a little lower position now. So either clopidogrel or ticagrelor can be given. Prasugrel is not available, I believe, in this country. Now, if the patient has severe chest pain, till the patient is being taken up for angiogram, you can give tirofiban, that is IV GP2B3A platelet receptor inhibitors. Anticoagulants should be initiated in all cases of NSTEMI, but in a very low risk case like unstable angina, it may be skipped. Now, invasive management. Invasive management strategy has been well defined now. Now, if the patient is a very high risk patient, that is having recurrent pain or a persistent pain unresponsive to management, or if there is any hemodynamic compromise like hypotension, LVF, or malignant arrhythmias, or extensive ST depression, more than or equal to 1 millimeter in 6 leads with ST elevation in AVR, the patient should be immediately taken up. If these are not present, but troponin is elevated, or transient ST elevations are there, the patient should be taken up within 24 hours, as early as possible. If the patient is low risk, that is no elevation of troponin, but that is basically unstable angina, you can do a selective ischemia guided invasive management. Now, the culprit lesion angiography is performed in all cases. Drug-eluting stents are recommended in all cases. In multivessel disease without cardiogenic shock, and if the lesions are simple and easily correctable, revascularization should be attempted in all lesions with the help of an FFR if available. Now, if the patient does not have any significant acute ECG changes and serial drops are negative, that is unstable angina, the patient should be taken up for a treadmill test evaluation. If positive, then take up for angiogram, depending upon the severity of the positivity. If negative, can be discharged. So this is the basic outline of management of NSTEACS. So the take-home message, I still emphasize the diagnosis of acute chest pain and ACS. The management part is always done by the specialist, so it is not very important for this thing. Every patient presenting with central chest discomfort merits evaluation of ACS. Never dismiss a patient as GERD or gas or and give some anti like PPI and send the patient home. Never do this. The nature of CP is very important, and the follow-up investigation should be viewed on the background of history and other findings. Serial high sensitive troponins are extremely useful for diagnosis and prognosis. And this should be available in all hospitals um, and clinics which deal with acute chest pain. This is widely available and it's very useful. Anti-ischemic management should be initiated in all suspected cases without delay. So whenever there is a working diagnosis of ACS on the basis of history and or ECG, the loading dose should be given without waiting for the troponin levels. Troponin levels will take about 60 minutes. That's the turnaround time. So before that, the treatment should be started because anytime such a case can go on to a STEMI or they can develop a cardiac arrest. So it should not be delayed. And only high risk cases need routine invasive management. Thank you so much for the kind attention.
Thank you very much for the super presentation. Sir has clearly explained the importance of history taking and clinical evaluation in chest pain, and Sir has clearly showed our prompt decision is actually life saving, and we are saving a whole family actually. The topic is now open for discussion. Thank you.
Yeah, if you make a mistake, then the guy will be cursing you in heaven, and the family will be cursing you on earth. So it's very important not to miss.
Now we have our cardiologist, Dr. Nitin. Dr. Nitin, can you add few points?
I think Sir has explained it very beautifully well. As he always says, clinical diagnosis is the most important. Actually, Sir doesn't like trophon, I think, he relies more on clinical. But something to just to discuss actually, there is. I just want to add once more that do not discharge the patient unless he's completely symptom free from the ER. I think that is the most important. If he has some form of chest pain or maybe upper abdominal pain or epigastric pain, then give relief of that. And if you're sure that relief is there, then only discharge. Maybe sometimes cervical spondylosis, other causes can also, musculoskeletal pain can also come. So if you feel it is that, you should treat that, and once it is relieved, then you should discharge. So don't discharge unless the patient is symptom free or significant difference in pain has come. And second point is like serial estimations. I think that is the most important part in diagnosis when you use troponin. Always try to get at least 2 readings, some spaced apart, and then you can use the protocol whatever is given in the in your lab reports. Actually, it is in our lab reports. It is mentioned how to actually Sir has made that changes also. So so you can read through that, and so it is easier for you. So serial estimation is very important, and especially the last algorithm slide which Sir showed us is really a gem. So I think that slide is very important. And third point is, in this time, actually COVID-19, it has there are a lot of cases where troponin elevation is there, and we are called for this, most of the time it is COVID-19, and it can produce very high troponin, even that what is not seen in ACS, actually acute coronary syndrome. It's seen as a very high, and it progresses very fast also. So sometimes the patient can come with borderline troponin, like an ACS with some chest pain. It could be COVID-19 once you test. So there is another diagnostic dilemma now. So that's COVID-19. So you should be very careful. Then another suggestion is triple screening CT, as mentioned, is very important, especially if you have some confusion to the diagnosis or you suspect something else, very high hypertension and all. So you suspect dissections, you want to rule out pulmonary embolism. In that also you can have troponin rise and all. But it is used in very selective cases, and never use CT coronaries for in diagnosing a patient with ACS. If you have doubt, since the probability of this thing is higher, you should always go for a regular cath. You should not use CT coronary for diagnosis in ACS, because And again, if you have the actual, I mean, proper treatment can also be done if you do a regular cath. So maybe in a patient unstable angina, and you're in place of the TMT to rule out acute coronary syndrome, you could use CT coronaries, or in such cases anyway, you can do it in a later stage. So in ACS, you should always depend on cath if you find there is a diagnostic dilemma. So otherwise, sir has given a very good talk. That's all for me to add. Thank you.
Thank you, Dr. Nitin.
Thank you, Nitin. Yeah, there was a time when I didn't trust troponins so much, but that was the time before high sensitive troponins. High sensitive troponins have made a sea change. Now, before this, the troponins were unreliable because of its precision problems, the coefficient of variation, its late this thing, and its levels were, its detection level sensitivity were very low. So you were missing a lot of true NSTEMIs as unstable anginas or non-cardiac pains because of this. So that is why now I trust high sensitive troponins so much, and our values are so reliable. I must congratulate Dr. Sangeeta for this because they are so reliable and we have never gone wrong.
Thank you so much, sir. Dr. Sangeeta here. Excellent
Yeah.
presentation. And I completely understand. And I would like to tell everybody that we are doing high sensitivity troponin T, and it is validated and calibrated almost every day. And we are running external quality cap controls as well as internal controls every day. So the precision, as you said, it is the precision and the accuracy of the test is extremely high. So the chances of going wrong is not there at all. It is monitored very closely. And I'm very happy that sir mentioned about our lab test. Thank you so much. Excellent presentation, sir.
That's our
Thank you.
lifetime, Dr. Sangeeta. I mean, without
Thank you
you,
so much.
we would have landed up in problems.
Thank you so much, sir. Thank you. Thank you.
Thank you, ma'am. Now, we have Dr. Santosh. Welcome, sir.
Yeah,
Good morning.
yeah.
Yeah. Please add few
Uh,
points, sir.
Thank you, Dr. Krishnan, for a very practical presentation. And I would like to add that we had patients who have presented, because many times patient himself will make the diagnosis. He will make a diagnosis of gas or tooth problem, and we had patients who had many teeth removed before coming to proper diagnosis. And so it is so important that proper diagnosis is made. Previously that it is not that the myoglobin is the first marker that becomes high in the first hour or something. Is it done anymore?
Now, that myoglobin was used for acute chest pain during the first hour. Uh, it's fairly sensitive for early detection, but its specificity is very low. So you overdiagnose a lot of cases, and I don't think it is now justifiable to use any of these. The recommendation now is to use only high sensitive troponin. You focus on that. That's the most important. Or troponin I. Both are almost the same. Same precision, same sensitivity. Only thing is that the cutoff levels are different.
Yeah. And sometime back, what I remember is that in the acute setting, that when you do PCI, you open up the culprit vessels, and is that is there a change in that policy?
Yeah, there is a change. Particularly in primary angioplasty, there has been a CISO. Thing. Initially, they said only culprit vessels, culprit vessel only. Don't touch the other ones. Then they said no, you can do a complete revascularization in patients with cardiogenic shock. And
Yeah,
then now they are saying for cardiogenic shock, do only culprit vessel.
yeah,
So currently, if you have a non-culprit lesion, which is FFR significant and easily doable in an uncomplicated case, So you should do a complete vascularization. But in shocks, shock only the culprit lesion. That's the current status.
Sir, I think it is multivessel plasty if it is safe to do it, because if like sir mentioned, is in shock, and you're also trying to stabilize the patient as early as possible. You have contrast load, so
Yeah,
there are a
there
lot
are
of issues.
several issues. So
So
initially the
so
argument
multivessel,
of
yeah.
shock patients, if you relieve ischemia of all the vessels, it will be better. But the cause of the ischemia is almost always the culprit vessel, and others are not contributing so much. And the contrast load and the duration of procedure will be more damaging to the patient. So a deferred strategy is better.
Okay, thank you. Thank you very much for an excellent presentation. Thank you.
Thank you.
Thank you, Dr. Santosh. Any more questions from the audience? Ajay sir, please unmute. Please unmute the mic, Ajay sir.
CT angiogram is reliable or not, Dr. Kunyam?
Yeah, CT angiogram properly done, because the problem with CT angiogram is first the heart rate, second the number of slices possible. So if you have a 128 slice machine and the heart rate is well below 60, then you get a very good this thing of coronaries. But the problem is that if the coronaries are calcified, there are calcifications in the coronaries, then you may not be able to have an idea about the lumen inside. You will see only calcium. So if there is no calcium and the lumen is normal, then you can, with 98% precision, we can say that there is no coronary artery disease. Having said this, I have seen at least 3 cases where the calcium score is 0 and reported as normal, but the pain was typical. We did the angiogram. Both patients had severe LMCA disease and went for surgery, confirmed. So I am not a great fan nowadays. If the pain is typical, you have to do further investigation. That's what I believe.
Sir, the CT angio has good negative predictive value, so I think
Yeah,
it is
I
used
agree.
more in ruling
In
out
spite of
rather
that,
than in.
in spite of that, ostial LMCA lesions are missed. I don't know why.
Is available here? Ahalia is
Yes,
available?
yes, it is available. It is available in our radiology department.
It is available.
Yes.
In acute coronary syndrome, the problem is that you don't get that much time to reduce the heart rate below 60 to make a diagnosis. So, for coronary arteries, that is a limitation. You have to prepare the patient and get the heart rate down. That is a problem. So it is
Oh,
not very
okay,
commonly
thank you, sir.
used. But if you have doubt of dissection and or PE, you have to do a CT.
Yes, Dr.
Okay, thank you.
Ajay. Ajay sir.
Uh,
Ajay sir was about to ask a question.
my usual it is yeah, it was an excellent presentation, and we GP usually come across the real concern about the one of typical
Voice
history
is
of
breaking.
strong family history of
I think voice was breaking,
myocardial
sir.
infarction.
Your voice was breaking actually.
His father, uncles will have a history, and they won't be having any symptom, but uh, I
Excuse me,
have
Ajay sir.
some
Excuse me, Ajay sir.
experience that
Voice was breaking actually.
The has undergone all possible investigations, not now. And one day night, he was
Now it is okay. Voice is
he
okay.
was
Sir, can you and Ajay sir?
can you please relate something about the families and families, strong families of is it right? I personally have and from it's a strong families of and the concerned patient will, not patient I will call, the concerned person will have a lot of anxiety. How will you deal it within a GP setup?
Ajay sir, can you please repeat the question? In between your voice was breaking, so we couldn't hear it properly. Can you please repeat the question, Ajay sir?
Sorry, I'll make it another day. Sorry.
No
I
problem,
want
sir.
to know about the strong families to of sudden
Now you
death
are audible very well.
and the
Okay.
patient's concern.
Okay, okay, sir.
Yeah, a strong family history is definitely a concern for the patient. Although family history, the significance of family history may not be as much as personal risk factors, it is an important this thing, and it is always advisable to investigate these patients with at least non-invasive investigations. Uh, it will allay the anxiety so much. So that's a very important thing.
Okay, thank you. So, if no more questions, we can conclude the session. The post-test as well as evaluation will be posted in the chat box and already posted in the AHH WhatsApp group. So please fill up the post-test and evaluation before concluding the session. And those who have experienced any difficulty, because we have launched a new platform, GoToMeeting. So if you have any difficulty in attending the sessions or any difficulty in between, you can contact us. We will help you in from our subsequent CMEs also. So thank you very much, Krishnan sir. Thank you once again for the excellent presentation, and see you all for the next Sunday CME. Thank you.
Yeah,
Thank
speaker.
you.